Hello, my name's Victoria and I work at the Marfan Trust. The Marfan Trust is the sole charity in the United Kingdom dedicated to improving and saving the lives of those with Marfan syndrome. Marfan syndrome is an inherited disorder of the body's connective tissue, manifesting in three main systems: the eyes, the skeleton, and more dangerously, the heart. Essentially, the glue, the scaffolding that binds the body together and keeps it in place, comes unstuck, resulting in, amongst other things, dislocated lenses in the eyes, flat feet, chronic joint pain, scoliosis, and, more seriously, aortic dissection. There are 3,000 people living with Marfan syndrome in the United Kingdom who are known to the charity, but there are many more, 15,000 by our calculations, who have this condition, some unknowingly. February is Marfan Awareness Month, and we are using this to search for the missing 15,000. Those who are living knowingly and unknowingly with this potentially life-threatening condition. In this short video, recorded at a safe social distance on the ubiquitous technology that is Zoom, Professors Graham Stewart and John Pepper talk of how they encountered Marfan syndrome and why they feel that greater awareness of the syndrome is so sorely needed. Thank you, watch and enjoy, and spread the word. Bye. When and how did you first encounter Marfan syndrome?
Gosh, a long time ago. So when I started as I was obviously aware of Marfan syndrome as a medical student and junior doctor. When I started as a consultant in Cardiff in 1993, I joined a clinic which was run by the local geneticist, by a lady called Dr. Sally Davis, where we had a joint clinic purely for Marfan syndrome. I was running the pediatric side and she was running the genetic side. So that's the very first time. And I was there for 6 years with some great clinics. I learned a lot from my colleague in clinical genetics, and then we developed our database for Marfan syndrome back then.
What drew you to specialize in Marfan syndrome?
Well, I'm a congenital and inherited cardiologist, so I look after people with conditions with which they've been born with, which often run in families. And what struck me was that it was one of these conditions that, from a heart standpoint, could cause quite a big problem, but you wouldn't necessarily have any symptoms from your heart beforehand. So really you had to be proactive and find patients with the condition in order to prevent them running into problems. And also, even way back then, there were some treatments which we could use which were effective. And rather than waiting till there's a catastrophe, diagnosing early. So that, I thought this was an ideal thing where you could be proactive and look for patients with the condition.
Brilliant. And finally, why do you think that awareness of Marfan syndrome is important, awareness amongst medical professionals as well as the public?
A huge amount has been learned about Marfan syndrome in the last 20 years. Vast amounts. Not only do we now know the gene that the abnormality that causes it in most people, we know that there are certain conditions that look like Marfans that respond in a slightly different way, that are not Marfans, and that early treatment does play a major role in preventing catastrophic outcomes. And that treatment may be medicines or it may be surgery. So I think it's important that patients are seen by a cardiologist or a cardiology team who are aware of these new interventions and new treatments and the importance of early diagnosis. And also aware of the family aspect. So if you see one patient with Marfan syndrome, you don't stop there. You then make sure the rest of the family members are assessed. And that's not what most doctors do. Most doctors deal with the patient in front of them. So it's really, really important that Marfan patients are seen in specialist centres where they're familiar with dealing with Marfan syndrome. They know when to intervene and how to intervene.
So when and how did you first encounter Marfan syndrome?
When I was a new consultant surgeon in the early 1980s, and we had acute admissions of patients with aortic dissection, that's to say, the aorta had become torn, And in some of these patients, they had Marfan syndrome. And I suddenly realized the complexity of the condition, which I had not really been faced with before. And I got more and more interested in that during the time when I was a consultant at St. George's during the 1980s. So that's how I got interested in the Marfan syndrome. And of course, at the end of that decade, the genetics of Marfan began to be sorted out. So it was possible to identify, particularly in the family of patients who'd had a complication, whether they had Marfan or not, and what the risk was. So that's how I got interested in Marfan, the necessity to treat acute dissections.
And what drew your interest to the heart or the aorta in the context of Marfan syndrome?
Well, as you know, Marfan affects many different parts of the body, the eyes, the spine, and the ligaments. But the most serious in terms of the risk to life is, of course, the effect on the large arteries of the body, particularly the aorta and its branches. And the part of the aorta that is most affected is that part that's closest to the heart, what we call the ascending aorta. I began to get extremely interested in that, both in improving our ways of dealing with acute injuries, acute dissections, but also whether it was possible to prevent these from happening and the effect of various preventing operations.
Would symptoms precede an aortic dissection? Is this why it's so dangerous that it could just be hiding in plain sight?
Yes, I mean, I don't want to alarm people terribly, but yes, this can happen. On the whole, mostly patients get extremely severe pain in their chest, going through to their back, sometimes into their tummy, but sometimes into the neck. And it's very severe, and this heralds the beginning of a dissection. But you can dissect with very few symptoms at all, as this. So I think if you are tall and lanky, or if you come from a family that is tall and lanky, as you put it, you need to get genetic testing and an echocardiogram. The genetic testing takes a little while to come through, a couple of months to come through, but the echocardiogram can be done fairly quickly. Of course, I know COVID at the moment makes it very difficult, but we should be out of COVID by the late summer. So an echocardiogram will tell you straight away whether there's a problem with the valve. So that's and also it will tell you the size of the aorta.